Foremost duty of a doctor is to take care of the suffering patient. Welcome back to Ophthalmology for undergraduates and postgraduate beginners. In the previous video, I presented a case and I arrived at a diagnosis. Now, let us see how to proceed with that patient. The diagnosis for our patient is right eye senile cortical immature cataract, left eye is senile cortical mature cataract with type 2 diabetes mellitus with systemic hypertension. Those people who have not seen the previous video, please go through it. Now, how to proceed with this diagnosis, what we have to do for this patient. First, when we ask any student, they always say, first I want to investigate. I ask them, what for you want to investigate? Investigations is of two types. One is diagnostic, other is workup towards treatment. So, investigations can be of these two types. As far as our case is concerned, everything is obvious. On examination itself, the diagnosis is 100% confirmed. So, we need not do any diagnostic investigation for this patient. When the diagnosis is 100% sure, as per protocols given in the book, we also know that what treatment to give. In our patient, pathologically, most affected eye is the left eye. The diagnosis is a mature cataract. Patient is having only perception of light vision. He is blind in that eye. There is only one treatment for the left eye, that is removal of the cataractous lens and implantation of intraocular lens. That is only going to give back the vision to the patient. As far as the right eye is concerned, patient is having an immature cataract. The visual acuity is only counting fingers close to the face. Now, we know that the visual acuity in an immature cataract can be anywhere between 6 vision to up to counting fingers close to the face. Now, we should make sure that the cataract only is causing defective vision in the right eye of the patient. There is no other pathology in the right eye causing defective vision. For that, we have to further evaluate the right eye, and if we are very sure that there is no other pathology in the right eye also we have to proceed with the cataractous removal and intraocular lens implantation. Having decided to operate on the left eye of our patient, we have to do certain workup towards surgery. There are 4 parts in the workup towards the surgery. One is the systemic evaluation to say whether the patient is physically fit for surgery or not. The second is ocular evaluation to say whether the patient is ophthalmologically fit for surgery or not. The third thing is prognostic evaluation. Any surgery you do on a patient will definitely ask you whether the surgery will be 100% success. Whether after doing the surgery, I will get back all the functions. So, you should be able to tell the patient what will be the outcome of the surgery. The next is surgical implant calculation. If you want to implant something into the patient's body, we have to calculate how much of measurement the implant should have. Then only you can place a exact implant in the patient's body or the eye to get back the function to the normal levels. As far as the systemic workup for the patient is concerned, the following things has to be done. One is, do a thorough general examination of the patient. Try to find out if there is any other pathology in their body. If it is so, we have to get the concerned specialist opinion and try to treat that condition before taking the patient for surgery, or get the no objection from the concerned specialist before proceeding with the surgery. As far as our patient is concerned, she is a diabetic patient. For all patients, we should do a blood sugar investigation. Our patient also compulsorily we have to do the fasting and postprandial blood sugar to rule out increased blood sugar levels. Blood pressure, if not measured in the examination, if the BP apparatus is not given in the examination, blood pressure has to be exactly measured. Our patient is a systemic hypertensive patient. If the patient having a normal blood pressure, no problems. If the blood pressure is very high, we have to contact the physician, get his help to control the blood pressure. You check for the blood urea and serum creatinine. Why blood urea and serum creatinine, you may ask? Any drug we are going to use for the patient during surgery, they are metabolized and excreted through the kidney. The kidney has to function normally to do the normal excretory work. If the kidney is at fault, then whatever drug you give will stay in his body or her body, leading to a toxicity. Check for the bleeding time and clotting time. Some patients may not reveal they are taking a anticoagulant drug, antiplatelet drugs. You have to do the bleeding time and clotting time to rule out no bleeding tendency is there in the patient. Next is, check the ECG of the patient to find out any cardiac abnormalities. Check the chest X-ray PA view of the patient to find out if there is any problem in the pulmonary system of the patient. Next is, do a HIV testing. The HIV is positive in a patient, then the patient will be immunocompromised. Then we have to take adequate precautions to prevent any infections following a surgery. Another one more thing is, surgeon also should take adequate precautions before operating on the HIV positive patient, because he may not want to get infected. If he gets infected during the surgery, that is the big problem in his life. The next thing is, rule out any septic focus in the body of the patient. Already when you do the general examination, check the ENT, check the tooth, check the nose, check the genitourinary system, check all portions of the body to rule out any infections anywhere in the body, because after doing a surgery, if that infection is getting into the eye, that will lead to endophthalmitis of the patient's eye, and that will cause a very big issue for the operating surgeon. As far as the ocular investigations or workup towards the surgery, we have to first measure the intraocular pressure by doing an applanation tonometer that gives the exact values. If the intraocular pressure is very high, the surgery can lead to complications like expulsive hemorrhages. So we have to know that the intraocular pressure is under normal values. Next, look for the nasolacrimal duct patency by doing a syringing testing. You syringe normal saline through the lacrimal punctum, and the patient is able to feel the flow of fluid into his nasopharynx, then the nasolacrimal duct is patent. If there is no flow, then there is an obstruction in the nasolacrimal duct. So there will be an infection inside the nasolacrimal sac, which may be very, very harmful following a surgery. So nasolacrimal duct patency has to be confirmed. Next is you take a swab from the conjunctiva and send for culture and sensitivity. We don't want any infections in a patient who is getting operated in the eye. So that is the main idea here. Next, do a complete slit lamp examination of the patient to rule out there is no any inflammation inside the eye. If you operate on an eye which is already inflamed, then the problem will get exaggerated following surgery and that may affect the visual outcome of the patient. As far as the prognostic indicators are concerned, in a mature cataract, seeing the retina, macula and optic nerve with an ophthalmoscope, that is a fundus examination, is not possible. The cataract is mature and so dense, the light will not pass through the cataract and you cannot see the posterior segment including the vitreous. When you cannot see the posterior segment, if the patients ask you whether I will get back the vision following surgery, you cannot tell the patient exactly what will be the outcome. So it is our duty to evaluate the patient furthermore to tell the patient what we expect after surgery. First, you should do a ultrasonogram of the eye, otherwise it is called as the B scan, bimodal scan of the eye, to see whether the retina, vitreous and the eyeball behind the lens is anatomically normal or not. So an ultrasonogram or a B scan will tell the posterior segment is anatomically normal or not. If there is any gross abnormalities, ultrasonogram will detect. Once we know that anatomically it is normal, we cannot stop there. We have to find out whether the retina behind it, the macula behind it, the optic nerve behind it is functioning normally or not. For that, we have to do a macular function test, retinal function test, optic nerve function test. So, what are all the tests that can be done under the macular function test? You can do a 2-point discrimination test. You can do a Maddox rod test. You can do a laser interferometry test. So, these are some of the tests we do to find out whether the macula is functioning up to normal limits or not. Next is the retinal function test. The retina can be examined by doing projection of rays test. Already in my previous videos I have told how to do this projection of rays test. If the patient is able to point out from which direction the light is coming, the opposite retina is normal. So that way we find out whether the retina is functioning normally in all portions or not. We can do a electroretinogram also to find out whether the retina is functioning normally or not. As far as the optic nerve function test is concerned, the simple test to find out whether the optic nerve is functioning well or not is pupillary light reflex. You throw light on the patient's pupil, the pupil will constrict briskly. Whenever the pupil constricts briskly, then the optic nerve is said to be functioning normally. The optic nerve function test does not stop with checking of the pupillary reflex. The optic nerve function as well as the functioning of the visual pathway can be assessed using this test called as the visually evoked potential or visually evoked response. This is a nerve conduction study to find out whether the optic nerve and the visual pathway are functioning normally or not. Whatever type of cataract surgery we do on a patient's eye will not give back good vision to the patient if an intraocular lens is not implanted. It is not just placing an intraocular lens, we have to place the exact power that is needed for that particular eye to give back a good vision. For that, we have to calculate the power of the IOL. There are so many formulas to calculate the power of the IOL, but the common formula we use and all the undergraduate students are fond of is SRK formula. Don't mistake for a cine actor. This is Sanders-Retzlaff-Kraft formula, which says that power of the IOL is equal to A minus 2.5L and minus 0.9K. What is this A? A is a constant for the intraocular lens. There are so many manufacturers manufacturing the IOL. So whatever the lens they manufacture, they have a specific A constant for that. To say as an example, the A constant may be somewhere around 118. Next is 2.5L. What is this L? L stands for axial length. The axial length of the eyeball should be measured using a scan. So by measuring that axial length, we have to put that values here. Next is 0.9K. What is this K? K is a keratometer value, corneal curvature value. So that is done with the keratometer, and the corneal curvature we find out that is somewhere around 45. So whatever value we calculate, we replace the K, and by doing the calculation we can find out the exact power of the IOL to be implanted in the patient. Having done all the workup towards surgery in the left eye of the patient, if there is no issues with the patient and the patient is physically fit, ophthalmologically fit, the prognosis is very good. Even if the prognosis is not good, we have to explain the patient that the patient is having a problem in the posterior segment. We may not expect a good vision in the eye following a surgery. We have to tell the patient. Next is we have to calculate the power of the IOL, and with this we have to get the consent of the patient. Any procedure you are going to do in the patient, the consent has to be got. In this patient, we should get a consent that you are having so and so problem in the eye, and I am going to operate on the eye. If the posterior segment is absolutely normal, you will get back good vision. If there is any problem in the posterior segment, according to that, the vision may reduce or it may be very low. All those things we have to write, get a consent from the patient, inform the relative also, get their consent also, get a witness also, then you proceed with the surgery. As far as the left eye is concerned, we are going to do a extracapsular cataract extraction with IOL implantation. That is the surgery we are going to do. So I have drawn 3 pictures here. So the basic principle of the surgery is, this is the mature cataract or cataractus lens with the capsule. In the extracapsular cataract extraction, we just open the central portion of the anterior capsule. The cataractus lens particles or matter is removed, and after removing it, we will place the intraocular lens inside the capsule and we finish the surgery. There are so many steps in the surgery. You can see so many videos available in the YouTubes for surgery, but the basic thing is this for extracapsular cataract extraction. There are several surgeries under extracapsular cataract extraction. One is a small incision cataract surgery, that is a manual incision cataract surgery. Second, you have a phacoemulsification. You can have a microphaco surgeries. All those things are there. But as you know, a mature cataract is a complete cataract. A cataract, if it is very hard, it may be very difficult to do a phacoemulsification or a microphacosurgery. It is always easy to do a manual small incision cataract surgery. But if the cataract is soft, then you can do a phacoemulsification surgery or a microphacosurgery also. Some surgeons, because of their experience, they can operate on any kind of cataract. So, as far as undergraduates are concerned, you should know that small incision cataract surgery, that is manual small incision cataract surgery, is always better for a mature cataract. Phaco and microphaco surgeries can be done if the cataract is soft and the surgeon is very well experienced in doing those surgeries. Now we have seen how to approach a case of a mature cataract. The same approach holds good for a hypermature cataract or grade 4 and 5 nuclear cataract. There is not much of a difference. So whenever you make such a diagnosis like a hypermature cataract or grade 4 and 5 nuclear cataract, you can follow the same steps towards workup for surgery, and the best surgery in all these cases is a manual small incision cataract surgery. With this, we will stop here today. We will continue with how we are going to proceed with the right eye of our patient in the next session.